Hello, and welcome back to the Aced It podcast. This is season 9, of course, where we turn science into sense. In this season, we provide 10 timely episodes with the hopes of helping listeners understand what we can learn from current research on harm reduction. And let me just say, there is so much here to learn. So, I'm glad you're with us. I'm Danielle Rudes, your host, and this is Aced It. Opioid overdoses kill thousands of people in the United States every year. There are a lot of harm reduction strategies and treatments that can be employed to help people prevent these deaths from opioids. Nearly 80% of people who have an opioid use disorder don't receive treatment, though. In this episode, I'm going to talk about an innovative method of delivering harm reduction where, get this, the harm reduction is brought to the patients. Let's start with going over some of the reasons that a mobilized harm reduction strategy is so innovative and important. As I mentioned, a large portion of people with an opioid use disorder don't get treatment. People who are experiencing homelessness or are vulnerably housed have rates of overdose death that is 20 times higher than the rate for the general population. Other people with an opioid use disorder do not receive treatment due to severe barriers like stigma in healthcare, correctional settings, federal regulations on the medications, and more. The office-based addiction treatment programs often don't offer a full range of harm reduction services. The author for this week states that the opioid overdose crisis is an epidemic of poor access to care. That's a direct quote. Craig Regis from the Kraft Center for Community Health in the Community Health Improvement Department at the Massachusetts General Hospital in Boston and his colleagues share the solution that has been implemented in Boston to help with access to care. This solution is the Community Care in Reach program, and it is the focus of this podcast episode. You may be asking, well, what is Community Care in Reach program? This program started in January of 2018 in the greater Boston area and is an innovative mobile health initiative that targets opioid overdose hotspots in the city. The aim of this program is to increase access to harm reduction services, addiction treatment, and primary care by bringing those services on demand and directly to marginalized individuals who are at the highest risk of death from an overdose. In their study, before the initial or pilot version of this study for the mobile unit, Regis and colleagues worked with the Boston Public Health Commission and the Massachusetts Department of Public Health to collect narcotic-related incident data to map the overdoses across Boston. This helped the researchers know which areas were hotspots to focus on. These areas with high rates of opioid overdoses also had a small amount of addiction services or street outreach existing, and they became 3 pilot sites. This pilot phase occurred over a 10-month period. The researchers utilized community engagement by getting the thoughts of stakeholders on the proposed model, which helped them to also establish channels of communication for the future. They spoke with Boston City Hall's Office of Neighborhood Services, ONS, which includes law enforcement, community health centers, business coalitions, neighborhood associations, homeless services organizations, and more. Now that we understand the overall of what the program is and the prep for the pilot phase, let's get into the specifics of a bit more on the program. The Community Care in Reach program has a 24-foot mobile medical unit. They had it built so that it's large enough to have a private and fully equipped exam room, but could still easily drive through the streets of the city. In addition, the van also had a sink, a wheelchair lift, reception area, electric-powered awning, bike rack, and 2 refrigerators for vaccines and food. The mobile unit schedules weekly clinics, and it has the flexibility to respond to emergent needs from other areas of the community. They even did this at one point in 2018 by leading a rapid response to reported infectious disease exposures in a neighborhood of Boston. There were several members of the health team on these vans as well. They had one buprenorphine-waivered clinician that had expertise in addiction and caring for homeless populations, and 3 harm reduction specialists from the city's syringe service program. For the harm reduction component specifically, there were staff from Boston's Access to Harm Reduction, Overdose Prevention and Education, a HOPE program. They would engage with people directly on the street and provide non-judgmental support and offer anonymous risk reduction options. For the clinical care component, there were BHCHP primary care physicians that had training in addiction medicine. There are so many services that this mobile unit provides. For risk reduction, there are things like naloxone kits for overdose reversal and unused syringes. For harm reduction, there are things like naloxone training, disposal of used syringes, HIV, HCV testing, and referrals to substance use treatment facilities. The clinical component, of course, is focused on expanding addiction treatment by providing things like medications for opioid use disorder, or MOUD. All of these services can be offered and tailored to the specific needs of each patient. By the end of 2019, the Community Care and Reach team had made over 9,000 contacts with people with opioid use disorder, distributed over 96,000 syringes, and almost 3,000 naloxone kits. Wow. This sounds amazing. But do we know if the mobile unit's pilot program was really achieving its goals? Well, Regis and his colleagues did an evaluation to determine this too. The researchers used a mixture of quantitative and qualitative methods for their study. Quantitative methods are those that focus on numbers, while qualitative methods focus on words. The quantitative analysis used coded clinical and harm reduction data from electronic health records. The qualitative portion included interviews conducted with patients of the services so that the researchers could find their perceptions and give additional context to the quantitative findings. The patients for interviews were selected based on things like frequency of their van visits, the type of their visits, anticipated availability, and anticipated willingness to participate. They were only approached for an interview when the researcher had permission from both the clinician and the patient. The researchers conducted semi-structured interviews from September to December of 2018 with 7 patients. Based on their study, Regis and his colleagues saw that there was an existing demand for mobile addiction services. They also saw a trend of services ramping up over time as the program became more established and built trust within the community. Importantly, their results showed that buprenorphine treatment can succeed in a mobile setting. This program was also seen as a great entry point for new patients, with over 55% of the patients being new. When talking to the patients, Regis found that there was a high acceptability of the model by the people who often experience stigma in more traditional healthcare settings. The patients particularly found valuable having a compassionate care option that was both predictable and flexible. One major benefit of this mobile unit, though, is the convenience of it. Patients also noted that there were successful engagement methods. There was a lot of good seen in the eyes of patients from this mobile unit model, but they also had some suggestions for improvements. These included expanding the hours, expanding the locations, and expanding outreach services or strategies to engage with even more people. There you have it. The Community Care and Reach program's invention, initial stages or phases, and success. Again, this program's goal was to provide targeted addiction treatment, harm reduction services, and primary care directly to individuals at the highest risk for near-term death from overdose. The program did just that. It was successful in providing services to this marginalized population who typically wouldn't receive treatment otherwise. The researchers are going to continue looking at their program in the future as well. Right now, the funding for it comes from outside public or private sources. One of the things they will evaluate in the future is what extent the program decreases the economic burdens on the healthcare system through reduced hospital stays and emergency department visits. With this knowledge, they can show that the program is cost-effective as an investment for state and federal funders. We all know that money talks, so this can be helpful for the continued success and sustainability of the program, not just in Boston, but in other areas as well. Community Care in Reach is a program designed to bring effective and evidence-based services directly to the people who need it most. We should keep this model in mind and look into if you can maybe implement something like this in your area. Thank you for listening to the ACEDIT podcast. We love hearing from you. So if you have comments, topics to suggest, or some science you'd like us to cover in a future season, please write to me, Danielle Rudes at Sam Houston State University. My email is drudes@shsu.edu. And of course, thank you to the Justice Community Opioid Innovation Network, or JCOIN's Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriters, Dr. Alyssa Toman from Texas State University and Sam Houston State University doctoral student Caitlin Bauer. And a huge and heartfelt thank you to Jason Luchin and the team at Slonky LLC for their spectacular production. Tune in again soon for another episode of ACEDIT.